the treatment landscape evolves for CLL, for some patient populations that need therapy, what is the rationale and evidence behind both dose escalation and dose reduction?
The question of whether dose escalate or dose reduce really depends on the treatment we're talking about. For new therapies like BCL2 inhibitors such as venetoclax, we do dose escalation at the beginning of therapy to mitigate potential side effects such as tumor lysis syndrome, whereas in most of the other scenarios, we will try to do dose reductions in order to mitigate adverse events. In all of these patients and in all of these cases, we do take into account the patient's comorbidities. In the case of venetoclax, for instance, we think of whether patients have kidney dysfunction, and in the case of BTK inhibitors, whether they have concomitant heart disease, hypertension, whether they are on anticoagulation, and also we take into account what other medications they have, in particular whether they have medications that affect their cytochrome P450 system.
Is there anything specific that you think healthcare providers need to know with regard to dose escalation and dose reduction?
So dose escalation in terms of venetoclax initiation is we already have a pretty well-established protocol that is on the label of the medication, and this is really mainly to mitigate the risk of tumor lysis syndrome. And in terms of dose reduction, I think it really depends again on which therapy we are talking about, and also on which particular side effect we're talking about. And so I really encourage all the providers to really inquire and look into what potential side effect the patient might have, so that you can adequately address this, because each side effect can be addressed or should be addressed with a different kind of strategy.